All right, welcome everybody to Grand Rounds June 2024. I do apologize, the camera is not working today, so you will just have the screen. Today we have Jeff Hashagen talking to us about Demystifying Lymphedema, a guide for healthcare professionals. Mr. Hashagen is a graduate of Misericordia University, where he completed his Master of Science degree in physical therapy, while also competing in NCAA men's lacrosse, earning all conference academic honors. He is a certified lymphedema therapist and an APTA credentialed clinical instructor. Mr. Hashagen has served as an adjunct educator and contributed to several academic advisory boards, as he views education of students as an integral development of the profession. His treatment philosophy includes hands-on patient-centric care with an individualized approach that addresses each patient's specific needs and goals. So again, please make sure you sign in either using this code on the screen or using the QR code. And I will also put this information in the chat. This is our CME credit information. The target audience is all providers. This is our designation statement, and this is our disclosure information. Neither the planners nor the presenters have anything to disclose. And these are our learning objectives, and they're also in the handout that you received. So without further ado, I will turn it over to Mr. Hashagen.
Thank you, Steve, and thank you for making this happen today. Hi, everybody. Thanks for attending, and hopefully we'll educate a little bit about lymphedema today and understanding what happens and what you should do when you see somebody who has some abnormal swelling. Number one, who am I? I ask myself that some days, but I have 20 plus years as a clinician. 17 years I've been with St. Luke's, and for the last 8, I have specialized in lymphedema and oncology rehab. I'm a certified lymphedema therapist, as Steve said, or CLT for short. Now we want to cover who can obtain their CLT. Okay, any current RN, OT, CODA, PT, PTA, MD, DO, athletic trainer, or a chiropractor, and certain massage therapists with certain criteria. What does it entail? The training itself. Lymphedema certification consists of 135 hours of intermediate level education, including a 45-hour home study, followed by a 90-hour class that includes live lecture and hands-on training. After passing all of your exams and completing the training, you obtain your CLT, and then you can also move on to do other specialties, specializing in head and neck, specializing in, some people just do upper extremity only, but the CLTs can treat the entire body. What does a CLT do? Well, we evaluate, develop, and implement a plan of care, very similar to normal rehab or seeing orthopedic patients, but obviously it's addressing symptoms more commonly associated with conditions such as primary lymphedema, secondary or acquired lymphedema, subacute edema related to trauma or surgery, chronic CHF, chronic venous insufficiency, or lipedema. The history of the lymphatic system was discovered in the 17th century by Olaf Rudbeck. Since then, anatomists, physicians, and researchers started to appreciate the complexity of the lymphatic system, its importance to bodily function, homeostasis, infection control, and circulation. But it wasn't already until 2015 that we discovered lymphatics were discovered in the meninges of the brain. As I oftentimes say to patients, healthcare is a science, it's not an exact science, and it's ever evolving. And that definitely is the case in regard to the lymphatic system and developing an understanding of not only how it works, but also how it's disrupted and how we can prevent those disruptions, and then also how to properly treat it. The lymphatic system itself has over 60,000 miles worth of lymphatic vessels present throughout the human body. You're calculating that's enough to go from New York to Los Angeles round trip 10 times. Obviously, these vessels are, for the most part, smaller than the size of human hair. You need a microscope to identify them. The basic anatomy of your lymphatic system starts with lymphatic capillaries. These are just below the subcutaneous layer of the skin and constitutes approximately 70% of the lymphatic system. You have lymphatic vessels, afferent, which are moving fluid toward, and efferent away, that are ultimately moving fluid towards lymph nodes, where there's a better processing of your lymph fluid. The lymphatic system is composed of larger vessels as well, including the right lymphatic duct, lumbar trunks, the cisterna chyli, and the thoracic duct. And when I say larger lymphatic vessels, the thoracic duct is the only lymphatic vessel that can truly be identified by the naked eye by dissection. The right lymphatic duct is responsible for drainage of the right upper quadrant of the body. So this includes your upper trunk, your upper extremity on the right side, and the right side of your head and neck. This returns fluid to the circulation of the right internal jugular, subclavian, and brachiocephalic veins. The thoracic duct is the largest of the body's lymphatic vessels. As I mentioned, this is the one that can be visualized. This drains approximately 3/4 of the body's lymphatics. So everything except the right lymphatic duct clearing area. This returns fluid to the left subclavian, the left internal jugular veins. The thoracic duct starts at the cisterna chyli. This is around level L2 at a lumbar spine. This is a fluid-filled sac, and it draws lymph up from both lower extremities through the lumbar trunks, and also draws fluid up from the intestines. Lymph nodes are what people are most familiar with when it comes to the lymphatic system. A lot of patients are familiar with, I can feel those lymph nodes in my neck when I'm not feeling well, they feel enlarged. An interesting thing about lymph nodes I always instruct, especially for breast cancer patients, is that you should never be able to feel a lymph node in your armpit. You should never feel axillary lymph nodes to palpation. You can feel them in your groin, you can feel them in your neck, but if you feel them in your armpit, you want to be making a trip to the doctor to have that investigated further. There's approximately 600 to 700 lymph nodes throughout the human body. They receive lymph from afferent vessels. Their main function is to serve as a filter. They monitor lymph and blood composition. They drain leaked plasma protein and excessive tissue fluid. They engulf pathogens. They augment immune responses, and they eradicate infection. They're small, bean-shaped, and like I said before, can enlarge when they're more active. You have organs in your lymphatic system. Primary organs include bone marrow and your thymus, which produces lymphocytes. Secondary organs of the lymphatic system include your spleen, your tonsils, lymph nodes, mucous membranes, and that's predominantly through your intestines. And this is all territory where immune cells are functioning. What is lymph? It's similar to blood plasma, but it's more watery. It's transparent, but has a slightly yellow tinge in color. Oftentimes, extracellular fluid leaks from the blood capillary walls and into the surrounding interstitium. Interstitial fluid pressure can build and then flows into the lymphatic capillaries and eventually returns to the venous circulation. It's important to understand that lymphatic flow is basically a pressure relationship. We're not relying on smooth muscle. Venous pump does help, okay, but a lot of this is a pressure situation. Your lymph is composed of lymphocytes, cellular debris, bacteria, plasma proteins, and when you combine cholesterol and glycerol and fatty acids, creates chyle. That's mostly lymph that is coming from the intestines, and that's when it starts to develop more of a milky, white type of substance when it's coming out of that cisterna chyli around level L2 and then up through the thoracic duct. Lymphedema, you'll see an ICD-10 code of I89.0, comes in a variety of forms. Primary is when your lymphatic system development is disrupted, creating absent or malformed vessels. The lymphatic system starts its development around gestational week 5. Okay? When you have primary lymphedema, it can be present at birth. There are cases where infants are born with swollen extremities, sometimes all 4. I've treated several children before with multiple edematous extremities, and this is something that will have to be managed for the rest of their life. Primary lymphedema doesn't always present right at birth. It can also develop later in life, oftentimes at puberty or even in adulthood. Very commonly, we see it develop in lymphedema tarda between 15 and 30 years of age. Secondary lymphedema, much more commonly seen, is acquired. This is when lymphatic function is disrupted from causes including cancer, infection, trauma, surgery, a variety of other causes beyond that. Those are some of the main ones you're going to see. I'll spend a little bit of time on this slide and looking at the staging of lymphedema. Depending on what you're looking at, some people talk about 4 stages of lymphedema. I've seen it as stage 1 through stage 4. I work off of stage 0 through stage 3. You'll see in the first image, you'll see upper extremity and lower extremity, 2 separate pictures as stage 0. If you look closely, you can see the right side of the body, so you're looking to your left, is what's considered normal. The left side of the body is where we're starting to develop the presence of some very mild edema. At this stage, most patients aren't even aware that they have lymphedema. I generally will classify stage 0 in my acquired lymphedema cases as anybody who has had radiation treatment, okay, or anybody who has had a lymph node biopsy or sentinel lymph node dissection in a lot of cancer cases. Some of my early chronic venous insufficiency cases. And the number one report that we hear from patients is it just kind of feels a little heavy or a little off, but they're not really noticing any changes in visualization in the mirror or changes in how their clothing fits. Stage 1, and I don't like to get too caught up in the nomenclature, but it's oftentimes called reversible. And this is where patients get confused because they think, oh, I can reverse it, it will go away. The reality is that once the lymphatic system is compromised, lymphangiogenesis does not occur well enough to reheal or restructure the lymphatic system to cure lymphedema. Typically, once you are diagnosed with a true lymphedema, it is going to be a lifelong condition. It's a disease and something that has to be managed. The term reversible more refers to you may wake up in the early morning and the limb is about its normal size. But as the day progresses, the limb is in a more dependent position. You have more activity throughout your day. You see an increase in the size of the limb. And you'll see if you look closely again, the dorsum of the hand is starting to show a little bit more edema compared to the unaffected side. Maybe you start to lose the creases in the knuckles. You don't see those as much. The tendon pathways are disappearing. Okay. You see a little more heaviness through the forearm into the elbow. Now, if you think about pouring water into a container, where does the water go? Right to the bottom. Okay. If you flip that container over, where does it go? Again, back to the bottom. So we're trained as lymphedema therapists that typically it fills in a stocking or a glove type presentation, but I will tell you I don't always see that. Particularly in a lot of my breast cancer cases, I find that edema will accumulate more through the axilla, through the armpit, into the proximal thorax, kind of in the triceps region of the upper arm, and very commonly you can palpate a heaviness through the forearm before I ever even start to see an accumulation of edema developing into the hand or into the fingers. In the lower extremities, I do tend to see more of that traditional filling in the lower legs, through the ankle, of course, across the dorsum of the foot, into the toes. You want to be sensitive with your patients when you use terms like sausage toes or buffalo hump of the foot, but that's some of the terms that you'll see out there in documentation. I prefer to call it dorsal foot edema or, excessively edematous toes. Stage 2 is now non-reversible, okay? And non-reversible means it's never really reverting back down to its normal size. Stage 2, I would say, is the most common case you're going to see was clinical presentation. That's when it's going to be identified either by a family doctor or specialist or you yourself as a therapist. Okay, there are times where patients are in the office, they're seeing one of my colleagues for orthopedic care, and it's noticed by my colleagues because they hear me talk about lymphedema day in and day out, and they call me over, hey Jeff, do you have a second? And we can identify, going through a patient's history, maybe there was a compromise along the way, and they've been living with this and have not known what to do. And in some cases, even their doctor wasn't quite sure. The stage 2 is non-reversible in a sense that it never goes back to your normal size. It will still see tremendous fluctuation. Some days it tends to be worse than others, and typically you're better early in the day, and it gets worse as the day goes on. And the main reason why it's typically better early in the day is people are elevated typically when they're sleeping. Okay, their arms are elevated, their legs are elevated, you're getting a better fluid return. Stage 3, in my mind, is something that really shouldn't occur anymore as long as those cases have been identified and properly treated. Stage 3 is what we refer to more as elephantiasis. You can see grossly misshapen limbs. Okay, you're losing function of those limbs. In the legs, you're going to lose knee or ankle range of motion. The legs are going to be very heavy to lift in and out of bed, in and out of the car. It's going to make walking difficult. It's going to make balance a challenge. Okay, there's a lot to consider beyond just the managing of the edema. Oftentimes when you're seeing these patients clinically, you have to manage the edema, you have to manage the infection risk, but you also are looking at managing safety with ambulation, functional tasks, improving their quality of life. Types of secondary lymphedema. Probably one of the most common that I will see is phlebolymphedema. This is predominantly chronic venous insufficiency. I refer to the garden hose analogy. If you have an old garden hose and you hook it up in the springtime and you go to water your flowers, the water comes through the hose, it's running from the faucet out the nozzle, it's making it to the flowers, but you look along the path of the hose and there's puddles along the way. Okay, that fluid is leaking out. It's the same thing with our veins. Fluid is leaking out from the veins and it's hanging out in the surrounding interstitial fluid or interstitial area. Okay, and over time the lymphatic system gets overwhelmed. Okay, oncology related, obviously surgery including removal of lymph nodes and or radiation treatment compromises the lymphatic vessels. Trauma or post-surgical, and lipolymphedema. This is when lipedema overwhelms the lymphatic system. You can see here a picture of what I term phlebolymphedema, starting chronically as venous insufficiency. Oftentimes you'll see varicose veins. You'll look in their chart and their history and you'll see maybe they've had a history of vascular procedures or ablation done. A lot of these patients have maybe had a history of a DVT or diagnosed with post-thrombolytic syndrome. Your clinical presentation is typically a very dry, scaling skin, scars from previous venous ulcers, or the presence of open venous wounds. You'll see mild to moderate pitting edema, hemosiderin staining, which is a darkening or rusty colored appearance to the skin. Sometimes you'll notice more erythema or redness with this. And that could be a challenge sometimes because I've seen patients diagnosed with cellulitis and it's not. It's more just a significant hemosiderin staining, and depending on the pigmentation of the skin, it presents more erythematic and looks almost like an infection. And then you'll also see very commonly an increased fibrosis or rigidity to the skin through the underlying soft tissue. Important to note with these cases, I don't always see a very large, voluminous presentation of the legs, but I'll see a lot of rigidity and hardness and fibrosis to the skin. And that's very common to see with these venous insufficiency cases that have advanced along and also compromised the lymphatics. Lymphedema related to cancer, in the upper extremity, you're most commonly going to see this in cases of breast cancer. Okay, We all know the pink ribbons, and we know that it's obviously a case that's very common with women, but I also include men in this because I've treated numerous men who have also developed breast cancer and have also developed lymphedema related to that. Procedure-wise, you can see biopsies, lumpectomies, mastectomies, reconstructions performed, sentinel lymph node biopsy, axillary dissections, all performed, and that can, in some cases, compromise your lymphatic system. The biggest misnomer is that, maybe it's something the surgeon did wrong, and that's not the case at all. When you remove lymph nodes or you have a surgery done that's affecting lymphatics, it can automatically compromise the lymphatic system. But even more damaging, the research has shown us, to the lymphatic system is radiation treatment. If you've ever treated patients that have had radiation treatment done, it looks like a really nasty sunburn. But think about that radiation is going much deeper, past the levels of the skin, past the subcutaneous levels, and into lymphatics and deeper. So it can do quite a bit of damage to lymphatic vessels as well. In the lower extremity, it varies. And this is one of those cases too where I'll mention I sometimes see more proximal edema in through the thigh, maybe into the knee, not as much into the lower extremity, but sometimes throughout the whole extremity. This is increased risk with abdominal surgeries and radiation treatment, again, to address cancer diagnosis, including, but not limited to, bladder, prostate, ovarian, vaginal, penile, testicular, pancreatic, lymphoma, rectal, anal, and intestinal cancers. Most of these procedures, or most of these cancers, are going to undergo procedures that involve radiation. And again, that can be very damaging to lymphatics, and then surgical intervention as well. The World Health Organization estimates 1 in 30 people have lymphedema worldwide. One thing I didn't really touch on in this lecture is the #1 cause of lymphedema globally, filariasis. Filariasis is a mosquito-borne infection, It's something that occurs, people associate it with third world countries. It's not. It occurs closer to the equator. Any countries closer to the equator. I had a gentleman that I treated who has lived in the United States the vast majority of his life, and he had lower extremity lymphedema just below his knee in one leg. He had no history, nothing that really jived or made sense until he mentioned that he lived in Africa as a youth into his mid-teenage years. And here he had developed a filariasis infection when he was young. That infection harbors itself in your lymphatic vessels. It does damage to them, permanent damage, and you can start to develop lymphedema. So we don't typically see it in the United States here unless people have lived, traveled outside of the United States and developed that infection when they're closer to the equator. So I didn't really touch on it too much today. There's up to 250 million people worldwide and 10 million within the US, based on an incident rate, that have lymphedema. It's a challenging thing to peg down in regards to the cancer cases, but estimates range as high as 30% incidence rate in breast cancer cases. Primary lymphedema is significantly more rare. It's 1 in 100,000 people in the United States. Population frequency has not been identified, but the incident rate suggested to be as high as 20% in post-traumatic lymphedema. Post-traumatic lymphedema, we're going to get into that a little bit more because especially in the orthotherapy world, you're going to see more of these type of cases. 10 to 11% of women, or approximately 400 million worldwide, have lipedema with the risk of developing lymphedema. So what is lymphedema? This appears when lipedema, obesity, and lymphedema present together. This occurs at stage 4 of lipedema when excessive adipose tissue puts pressure on the lymphatic vessels, compromising the lymphatic system. Incidence is predominantly in the lower extremities of women. Expanding further on lipedema, this is an adipose tissue disease. It is unevenly or unusually distributed beneath the skin. Very commonly, it appears through the buttocks and lower extremities, but is foot sparing. Symptoms include pain, swelling, bruising, and a lack of response to traditional weight loss methods. A lot of times I see women in my office. It's much more prevalent in women, and they'll be in their 40s or 50s, maybe in their 60s, okay? And we'll talk about their history, family history. Very commonly, we'll see this shared amongst sisters or mothers or grandmothers that they'll say, you know, they had very large legs too. And this is this, for lack of better terminology, that kind of cottage cheese type of presentation that you'll see to the skin and the tissue just below the skin, where it's not typically very heavy in lymphedema. You can really palpate and press and move it, but it can be very painful. These patients can bruise very easily, okay? Oftentimes, when young, in adolescent years, patients will look like two different people. They'll be skinny from the waist up and very large from the pelvis down, but then it generally doesn't involve the feet. When we start to see more swelling in the feet, that's when we start to see the lymphedema, where the lymphatics have been compromised. The adipose tissue cells continue to proliferate and proliferate and proliferate, and then eventually they start to strangulate your lymphatic vessels, and it prevents your lymphatic vessels from adequately clearing, and you get this buildup of lymph fluid, and now you have lymphedema. It can happen in the upper extremities. I actually have two cases, very rare, but I have two cases that I'm treating right now. These could be a challenge to treat. The arms are large, again, bruise very easily. Oftentimes patients can cut their arms open very easily, have issues with healing of wounds. And we see a cuffing or bracelet effect at the wrists. This is what really makes it challenging to apply compression. And then also because that skin is more malleable, when you put a compression garment on, it just kind of slides down the arm and doesn't stay in as well. These are challenging cases. Post-traumatic lymphedema, okay? Development of post-traumatic lymphedema. Lymphangiogenesis, or lymphatic repair, occurs roughly between 1 to 3 months after trauma. So you have wound healing and inflammatory response, and there's going to be some pain associated with this, as you see with anybody who's had surgery. But as scar tissue develops, it can potentially disrupt the continuous lymphatic vessel flow. I cannot stress the importance more of scar tissue massage. When I treated more orthopedic cases, all my total knees, and there are a variety of different treatment methods, whether it was laser, instrument-assisted mobilization, or it was just good scar massage, reducing the adhesions. The importance of this is not just to make the scar look pretty again or restore normal pigmentation to the area, but this actually helps to enhance and improve lymphatic flow and prevent restriction from chronic scar tissue building up. Lymphatic disruption can occur beyond 3 months and now become pathologic. So injury patterns associated with this in musculoskeletal cases, fractures, both non-operative and operative. I have a woman that I'm treating right now. She fell. She fractured her humerus. It was non-operative. She was going for her orthopedic rehab as she was healing, but her arm was just swollen. It wasn't improving. It wasn't reducing. And then she was referred to me. We have her in a compressive sleeve now. We've educated the family on manual lymph drainage. I've been performing manual lymph drainage, and she's really seen a reduction, is doing better. She can move her arm better now. I see a lot of, or a fair number of, post-total knee replacement, post-total hip replacement, where maybe there are some indicators in their past medical history, like a venous insufficiency or history of DVT, that precluded them to maybe being at a higher risk. And then that surgery just kind of put them over the edge, where they did not recover from the inflammatory response of healing, and they have chronic edema that's now limiting knee range of motion or preventing them from getting back to doing what they need to do. And we treat that edema, reduce it, and we get their full knee range of motion back. Burns. The prevalence of lymphatic vessels being just below the subcutaneous layer of the skin can yield a high risk of damage in cases of deep burn injuries. There are abdominal patterns, and they're more rare, but it's generally caused by a penetrating or blunt trauma. This is oftentimes surgical, and I've seen numerous liposuction cases. Okay, patients that go for liposuction, whether it's cosmetic or medical, and it leads to an accumulation of excessive edema in the abdomen or rigidness or fibrosis that needs to be treated again by CLT. So again, I kind of touched on some of this, but how this applies to orthopedic PT. The main cases of concern that I see are post-operative, knees, hips, shoulder surgeries, skin grafts that are performed, or liposuction. Following a fall, a patient can strike their limb or extremity and have a contusion that's just not healing or is getting more swollen, or a fracture. Post-injury, crush injuries or sprains and strains, and chronic conditions such as chronic pain syndrome or complex regional pain syndrome. And to touch on that, and we'll get more into manual lymph drainage, but manual lymph drainage is very light, it's very superficial, and I see a lot of patients respond well to the manual lymph drainage massage techniques because it's soothing and it helps to relieve some of their pain. Critical lymphatic areas of the body. These are areas where there's increased density of lymphatic vessels. This creates a susceptibility to disturbance in those areas. So in the lower extremity, the anterior medial leg, the medial thigh, and the medial aspect of the knee. A lot of the lymphatics from your lower leg drain to the inside of the knee because it's a protective design. So if a lot of times you strike the front or the back of your knee, the inside is more or less likely to be struck, so they're less likely to have trauma to the lymphatics. In the upper extremities, you have medial aspect of the arm or medial elbow. So while it drains lymphatics to these areas to kind of protect them, if you see an injury to those areas, you might notice that that patient's more susceptible to holding on to chronic edema. The most common comorbidity that is associated with lymphedema is obesity. Okay, it doesn't mean that everybody who has lymphedema is obese. I have seen patients that it's hard to really even identify their lymphedema because they're very skinny. All right, but you take the measurements, you do the physical assessment, and you notice they actually have lymphedema. But obesity is the most common comorbidity. There is conversation in the lymphatic community about whether obesity causes lymphedema. Some will argue that the large size of a pannus can compress your lymphatic vessels and affect your lumbar trunks and increase the likelihood of developing lower extremity edema. Diabetes, oftentimes very commonly associated with obesity, also going to be commonly associated with lymphedema. These are not causes, but commonly we see these diagnoses along with it. Cancer, chronic venous insufficiency, post-phlebitic syndrome, venous disease, and congestive heart failure. So when you want to treat lymphedema, you want to think about precautions. They're pretty short list, but sensory paralysis, open wounds, chronic congestive heart failure, and occlusive peripheral arterial disease. These are precautions. These are areas that I maybe want to check with their family doctor or their specialist to make sure that they're 100% clear to be treated, but they're not going to preclude me from treating the patient. Contraindications are acute congestive heart failure, okay? Acute venous thrombosis, cellulitis infection, acute inflammation, acute renal failure, peripheral arterial disease, or malignant tumors. These are cases where if I'm identifying these things, and sometimes I'm the first one to identify this, they're sent to me because of excessive swelling in a limb, but we see something worse is happening. You're generally referring them either to their family doctor, urgent care, or the emergency room. Cellulitis. I'll touch on this one because it's something that almost every clinician is going to see at some point in their career in their office, whether they're treating somebody for lymphedema or not. Cellulitis is a skin infection, okay? There's redness that generally presents in non-map-like borders. There could be a swollen appearance to the area. There's generally pain, and there's an increase in warmness to palpation. You can see in more worse cases blistering or pus-like appearance. And in more severe cases, the patient will develop a fever, chills, or malaise. Now, the concern here is when you catch cellulitis early, you can treat it very easily with antibiotics, okay? But if not caught early enough, this is usually leading to a hospitalization and oftentimes IV antibiotics. And in a worst case scenario, the patient has become septic. I've seen this happen. I've seen patients have recurrent cellulitis infections to the point that they no longer respond to normal antibiotics, and they need the IV antibiotics. And in extreme cases, this sometimes leads to amputation. So identifying the infection as quickly and early as possible is very important. If you're seeing a patient on a Friday, don't necessarily wait till Monday. Okay, get it taken care of, get them to urgent care to the ER right away. So complete decongestive therapy is our main method of treatment. Okay, what are we doing with complete decongestive therapy? One of the main components is manual lymph drainage, okay, or MLD. This is a skilled and specific manipulation of the skin to increase lymphangiomotoricity, or the movement of lymph. We generally want to complement this with compression. The proper selection of a compression garment and/or compression bandaging is what's going to effectively reduce limb volume, contain volume, and prevent worsening. Probably my biggest pet peeve is when a patient is sent to me and they were prescribed compression stockings. Oftentimes a clinician will see a patient has swelling, so they think, well, you need a compression stocking. The problem is that patient is in an edematous state. And in my opinion, compression has solely one job, or predominantly a compression stocking has solely one job, and that's to contain, not necessarily to reduce. I oftentimes would much prefer that a patient is referred to a lymphedema therapist who can evaluate them, initiate things like manual lymph drainage, and in some cases, more effective compression for reduction, such as bandaging or compression wraps. And then once the optimal volume is controlled or reduced, then we fit them for a compression stocking, which will then contain their lymphedema. Too many of these patients go, they waste their money, they waste their time in getting these garments. They're ineffective, they're uncomfortable, they're cutting in, they end up in the back of a drawer or a closet and not effective. So manual lymph drainage itself was developed by Dr. Emil Vater and his wife Estrid. Even in 1936, he was smart enough to know to credit his wife as well. He has the technique has a very light and gentle, technique where it's capturing and stretching of the skin. The idea here is you're not gliding or sliding or kneading. You don't want to be compressing on the skin. You're really optimizing the surface of your hand to capture the skin and move it to as far as a stretch or maximal stretch as you can achieve. And the concept there is that it's ultimately pulling on the anchoring myofilaments, or these little strings that are attaching the lymphatic capillaries just below the subcutaneous layer of the skin. And that's enhancing this pressure-based relationship to move fluid in the interstitium into the lymphatic capillaries. Movement is distal to proximal, okay? So if you're treating a lower extremity, you're moving from the direction of the toes towards the heart, okay? If you're treating the upper extremity, you're moving from the hand up towards the axilla. But you want to clear your proximal or unaffected segments first. I use the analogy. If you have company coming over, all right, and you have a messy living room, and you want to take all your mess and put it in a closet, odds are if you have a messy living room, you've got a messy closet too. So you've got to clean the closet out first to make room for all the junk that's in your living room, okay? Same principles apply here. You could just be stuck pushing fluid against fluid if you start distally, all right? You want to work your proximal segments first with a movement that is going from distal to proximal. There's 4 main strokes: stationary circles, scoop, pump, and rotary technique. Manual lymph drainage utilizes healthy anastomoses. These are pathways that cross watersheds, and watersheds are essentially lymphatic boundaries in the body. The main ones we focus on for treatment are mid-sagittal. It's basically cutting your body in half from left to right. You have your transverse, which is basically cutting you at the waist from north to south. You have clavicular, which works across the clavicles, obviously, and spina to scapula. Again, kind of back in the shoulder blade region. And I focus more on clavicular and spina scapula in some of my upper extremity, but very much a lot of my head and neck cases. Okay, so an example of this would be if you have a compromised left upper extremity, you have left upper extremity edema, and maybe there was a lumpectomy performed just on that left side. Well, we know that the right side is unaffected and appears normal. All right, so we can create an anastomosis or a pathway to move fluid from that left side all the way over to the right axillary regional lymph node bed. Okay, or we can direct fluid downward towards the healthy left side inguinal regional lymph node bed as well. And that's what we use these anastomoses and cross these watersheds for. The intensive phase of manual lymph drainage includes treatment that can range from 2 to 5 sessions per week, depending on the severity of the case, usually dictates how often we're seeing the patient. But as we can all appreciate as clinicians, there's a lot of other factors, including transportation, cost of care, co-pays, and so forth, that oftentimes can dictate our plan of care and our decision-making and how we carry this. It includes education on self or assisted manual lymph drainage. I absolutely encourage patients to bring a loved one in or a family member or an aide. I can teach how to perform some of these assisted manual lymph drainage techniques. And then I also teach patients, if able, how to perform their own self manual lymph drainage. As long as they're following the proper movement, as I always say, circulation back to the heart essentially, something is better than nothing in a lot of these cases. Research has shown us that manual lymph drainage can reduce the amount of volume by as much as 300 milliliters within just 3 weeks' time. It's also proven to be very effective in palliative care and in treating post-surgical and post-traumatic edema. Not only does it help to clear fluid, but it tends to be soothing and relaxing for patients and helps reduce pain. When we move on to compression, on the shorter term of things, we're generally going to look at maybe bandaging. This involves short stretch bandages. I have here in capital letters, do not use ACE wraps. Okay, short stretch bandages do not have a lot of elasticity. Elasticity is generally not our friend when we're trying to achieve compression, so we try to avoid the use of ACE wraps. Bandaging can include toe and finger wraps, bandaging from the hand and the foot through the entirety of the limb to the axilla to the groin. The downside of bandaging is it can create temporary functional deficits, such as difficulty with walking or balance issues, an inability to drive, or work duty complications. So this is something that's always a consideration when I'm looking at how I'm going to treat my patients effectively with compression. One thing that I definitely want to talk about is that, when I'm looking at a patient and what's going to be the most effective method for bandaging or compression is if a patient can only see me twice a week. It's 2 days in a week, and if I bandage them and they can maintain it for 24 to 48 hours, maybe that's 4 days a week that they're bandaged, but there's another 3 days that they aren't. So in some cases, we decide bandaging just isn't the best way to go. Maybe they can be safe with it, but it's just not enough compression for a period of time. So we go to a garment such as a Circade or a Medisolaris wrap. These are Velcro wraps that patients are much more easily able to apply. I use these generally in the lower legs, but they make them for the knees, for the thighs, and even for the upper extremities. Compression stockings come in a variety of options: knee high, thigh high, open and closed toe. You have gloves or gauntlets, arm sleeves, you have compression bras, corsets, and you have head and neck garments. They can range in a compression rating anywhere from as low as 10 to 15 millimeters of mercury to as much as 50 to 60. You're generally going to decide on that based on the presentation of limb, how much you feel they need compression-wise, and if they're just starting out with compression, I generally start them on the lower side to build a tolerance. In the upper extremity, oftentimes I'll start with 10 to 20. In the lower extremity, 20 to 30 millimeters of compression. This is just a picture here of what those Velcro wraps look like. Okay, this is one being applied to the leg. And then when you look over at bandaging here, you can see it's a multi-layer system. I usually have some tuba grip underneath after I've applied some lotion. In some cases, you're having to dress a wound. And then I usually use some Comprofoam or gray foam, and then a series of bandages in a sequence here. And then you see this last image on the right, which is a full leg that is bandaged from toes all the way to groin. Compression no-nos. if you turn your attention to the picture here, this is an example of a patient that is status post a total knee. They're getting ready to cycle around on the bike, and we just removed the ACE wrap that was given to them to be used to help control the edema in their leg. If you can take a look at this picture, you can see why I'm not a fan of ACE wraps. Very, a lack of uniformity, no even compression there, and it's leaving all these ridges, and in some cases can slide down and tourniquet the leg. Not necessarily the vasculature, but can tourniquet the lymphatics and cause an increase of lymphatic accumulation in the leg unnecessarily. So compression no-nos on my list are prolonged ACE wrap use. You want to avoid layered proximal compression. Well, what does that mean? Well, if I have compression on the leg, okay, and I go with an even higher level of compression, or I have an overlap, say in the lower leg to the knee, it's almost creating, instead of maybe a 20 to 30, now almost a 50 at the knee. That's too high of a compression at that area if you have a lower compression rating below that. Okay. Folding compression garments to fit. This is a big one I see. Patients will order a stocking or compression socks online, and they come in and they go up past the crease of the knee. So to avoid them rolling down and cutting in, they just fold them over. Well, now you're almost doubling up your compression, and that's something you generally want to avoid. You want to make sure you're fitting patients for these things. You're choosing the proper size, whether it's a regular, a long, or a short, or petite. Compression that's too tight is going to cause numbness or drastic pigmentation change, or can restrict blood flow. You obviously want to avoid that. And this is why when I apply compression to patients, I generally try not to just usher them out of the office right after it's applied. I want to at least give a few minutes or a bit of time to make sure that this isn't happening. The law of Laplace, okay. The law of Laplace ultimately tells us that if a bandage is applied with constant tension and overlap, the pressure applied at the calf will be lower than that applied at the ankle, with the understanding that the ankle circumference is typically smaller than the calf. So I always explain this to patients. This is like a river flowing into a larger body of water, a delta, right? It doesn't get really narrow as that river is flowing into a larger body of water. It starts to get wider and wider. So you have that conical shape and allows for a better flow or movement of fluid. Same thing applies in the body. You'll see pictures here of what maybe a compression sleeve and a glove might look like, or a gauntlet might look like here for the upper extremity, and then what a compression might look like in the lower legs and the thigh-high garment. Okay, they come in a variety of options off the shelf. Jumped ahead there. Off the shelf, custom, or day and nighttime garments. In my less severe cases, we just worry about daytime garments. In my more significant cases, we have nighttime garments as well. The other main component for me for CDT treatment is education. All right, skin health and hydration is paramount. All right, you really want to educate patients on generally applying lotion daily, monitoring their skin health, and doing daily skin checks. Want to be monitoring for infection risks, so any indication of redness, warmth, abnormal swelling beyond what they're used to. Okay, a lot of time spent on donning and doffing garments and proper garment care. Limb hygiene. There's a lot of my patients who have difficulty managing their toes. Some go to a podiatrist to have their toes trimmed, some don't. Some have infections in their toes. It's difficult for them to reach down, and now you add the edema component, and it's very difficult to even get into that space between those toes. Home compression pump. Home compression pumps can be very effective and useful in certain scenarios, but I typically refer to them as the best, worst option available. Okay, the gold standard for care is complete decongestive therapy, being manual lymph drainage, compression options, and education. The home compression pump I find is best used for home. It works segmentally and generally helps to simulate a form of type of manual lymph drainage, and I think can be very effective for the long-term care and management once a patient is beyond the intensive phases of treatment. And then last but not least, lymphedema exercise. Okay, some of this is just remedial exercise, getting up, walking around the home, maybe doing some bicycling or cycling, ankle pumps, heel raises, toe raises, elevation of the legs, long arc quads, those type of things. I have to go through a couple different case studies here. These are all patients that I have seen or are actively seeing. Case study number 1 is an 83-year-old female. All right, she complains of bilateral lower extremity swelling, left greater than right. This has progressively worsened over time. It now affects her walking, her balance, and she's having a significant amount of pain with the presentation of superficial weeping wound bed. Her past medical history is significant for venous insufficiency, hypertension, chronic congestive heart failure, peripheral neuropathy, the history of left total hip replacement, and she lives alone, but has the assistance of her 72-year-old sister, occasionally with meals or to take her to appointments. So, this patient came to me, and there's obviously cause for concern. Anytime you see a wound that is bleeding or weeping with fluid, that's a cause for concern. And the question always becomes, should this patient be in my office or should they be at wound care? All right. And sometimes it's a judgment call. Are you able to treat this or are you not? I've had patients that have been attending wound care for well over a year. No knock on wound care, but repeatedly dressing the wound without effectively addressing the compression is not going to allow for adequate wound healing. So sometimes the doctor will reach out to me and say, Jeff, I got this patient with these wounds. They're not too deep. Should I send them to you or should I send them to wound care? And I typically say, let me see them first. Let's see if we can address the edema. And oftentimes when we do address the edema, you see something like this. This is about 3 weeks out from me initiating treatment with the patient. As you can see, no more weeping. The skin has dried out now. No bleeding, and the wounds have closed. If I go back, we can also see kind of some ridging here towards the ankle, and we can see the presence of edema and a little bit worse erythema here. All right, and I go to 3 weeks later, less ridging, the overall limb size is reduced, and that's allowed those wounds to just naturally heal. Okay, generally I will start off care and I'll be monitoring wound healing. If I'm several weeks in to almost a month in and I'm just not seeing the progression that I want to see with the wound healing, that's generally when I'm referring out to wound care. Okay, and there's a lot of clinical decision making and rationale there depending on the presentation of the wound. If there's a deeper concern right out of the gate and you think it's beyond your capability, absolutely don't hesitate to send them to wound care. All right. So her diagnosis I gave her was bilateral lower extremity phlebo-lymphedema. This is a mixed edema, all right, due to the chronic venous insufficiency and acquired lymphedema, left greater than right, likely because she had a left total hip replacement. It's affecting both of her legs, but the left is worse. And I think the one precipitating factor that just put the left leg worse than the other over the top was the hip replacement. Even though it wasn't recent, it was just several years prior. Her plan of care, how did I treat? Well, I did modified manual lymph drainage of bilateral lower extremities. And I say modified. There's a full sequencing for manual lymph drainage where you clear from the neck through the abdominal region, then the inguinal region, and then the proximal thigh and the knee and the leg and down into the toes and then all the way back up. In a lot of my chronic congestive heart failure patients, I choose to not do the clearing of the neck and not do the clearing of the abdomen, but I rather just clear from the inguinal regional lymph node bed down through the leg and then back up so as to promote improved lymphangiomotoricity, greater movement of fluid, but not to potentially send too much fluid to avoid overwhelming the heart. And it's not like we're rushing this back. We move fluid, the lymphatic system moves fluid at the rate of several liters per day, where the arteriovenous system moves fluid at the rate of several liters per minute. But I err on the side of caution, and this seems to be pretty effective. Her wound care I managed with zinc oxide cream and non-adhesive bandage and gauze. And then I was using Circade compression wraps for the lower extremity compression. Case study number 2. This is a very classic example of lower extremity lymphedema that I'll see. Both legs are edematous. The left is much larger than the right. This is a 59-year-old male with chronic bilateral lower extremity edema. Presents initially with weeping of the left leg. Has a history of cellulitis infection that was treated with antibiotics. And comorbidity includes severe osteoarthritis of both knees, morbid obesity, hypertension, and venous insufficiency. The patient works overnight in manufacturing and is in dependent position for prolonged periods. This is a challenge. I oftentimes refer to trying to clear edema out of a limb as if you come home from vacation and you discover your basement is flooded. All right, you identify that there's a pipe that's burst. What's the first thing you do? You turn the water off, okay? Then you fix the pipe as you're clearing the water out, and then you turn the water back on. Treating a lymphedema patient, especially a case like this, is like trying to empty the water out of your basement without ever turning the water off or ever fixing the broken pipe. Remember, lymphangiogenesis won't occur here. The lymphatic system will not heal itself. What's compromised is compromised. This leg has gotten out of control and should have been treated in an earlier phase. So the challenges here are that you'll be able to do manual lymph drainage, you'll improve lymphangiomodicity, you'll apply compression and get the limb side reduced, but you have to keep repeating this over and over again and get the limb as optimally reduced and then get them into the proper compression garments that can best hold and contain this leg. Here's some more pictures of this patient. Take notice of the toes. Look at that presentation. The amount of edema that has accumulated in the dorsum of the foot and into the toes, affecting toe health, obviously. You can see the changes in the toenails, okay? This other picture to the side here, this transition point can be difficult for bandaging. I'll generally pack this with copper foam or gray foam to create a nice transition so that my bandages cover and compress appropriately. As you get up towards the knee, you can see the amount of edema that has accumulated in the proximal calf and into the thigh and along the medial component of the knee, where we already talked about how your lymphatics drain more medially, so see a large accumulation in this medial side. This will restrict knee range of motion on somebody that already has severely arthritic knees. You can understand how his balance and walking can be very challenging. So my concerns here are the dry scaling skin, hyperkeratosis, numerous skin folds, limited range of motion, and back on those numerous skin folds, you want to be inspecting these areas every time you treat a patient and cleaning these areas as well as you can, because this is an area where infection can harbor itself. So limited range of motion, poor ambulation potential, irregularity in limb shape, edema presence, toe health, and the erythema along the medial compartment of the knee and the thigh. All that needs to be addressed. So my plan of care included full sequence manual lymph drainage, compression bandaging. We were doing below the knee because walking was already so difficult for him. He wouldn't be able to walk if I bandaged all the way up to the groin. Skin care, Cercade compression wraps, and the goal of custom compression stocking, fitment, and self-care. We're trying to work that patient towards that right now, and some of his orthopedic issues have been limiting his attendance at appointments, and it makes it even more challenging. Case number 3 is a 76-year-old male with onset of right greater and left facial edema, most prevalent in the cheek with greatest accumulation below the jaw line into the anterior neck. Significant scar adhesion of the right anterior lateral neck along a now healed incision site from his radical neck dissection to address head and neck cancer. Surgery was performed 6 months prior, and then he had radiation treatment of 33 sessions. This has yielded significant fibrosis within the right anterior lateral neck to supraclavicular fossa. Patient is retired, he lives with his spouse, and is otherwise healthy for his age. So this is not my actual patient. This is a kind of a stock image, but this is very commonly what you will see. And you'll see this kind of area underneath the chin, all right, this gaping down, the skin dropping. Very commonly, this area will fill with fluid. Where his neck dissection was actually done, in this case, was on the right side. It's cutting in, it's tighter, it's actually a little more fibrotic because of the radiation treatment that was done. It's hard to see in this picture. And then you'll look up towards the nose and just towards the corner of the mouth, and you compare both sides and you can see the differences. One side is filling more of the fluid into the cheek, and the other side you can see, just like a deeper groove there because he doesn't have that presence of fluid. You see the picture off to the side, that's an indication or kind of a generic show of where a radical neck dissection typically is. You're generally cutting anywhere from just the base of the ear all the way down to a midline in the neck. Key considerations in this case is you want to anticipate there's going to be neck and shoulder range of motion deficits. Radiation fibrosis and scar adhesion can create skin degradation and poor soft tissue mobility. The patient may have swallowing, speech, or throat clearing issues, and sometimes they have coordinated care with speech therapy. Patients often self-conscious regarding the change in appearance. All right, you can maybe hide a limb in a shirt, okay, or in pants. It's hard to hide swelling in your face, your head, or your neck. Plan of care includes patient education, self-manual lymph drainage, home exercise program to include facial muscle activation exercises and cervical range of motion and shoulder range of motion, manual lymph drainage, clearing of the neck, face with anastomoses to both armpits or axilla. Scar massage is a big one because, again, we talked about scar adhesion can restrict movement of lymphatics. And compression garments. Sometimes I fill these compression garments with gray foam, or I do what's called chip packing to get a better compression on the area that's more swollen. And you see this little picture here, that's an idea of a generic compression garment for head and neck. You can understand why patients don't really want to be wearing these outside of the house. So I generally encourage wearing inside the house versus outside. Case study number 4, and our last case study to wrap up here, is a 58-year-old female status post bilateral mastectomy. Following breast cancer diagnosis with chemotherapy and radiation, she had 15 sessions with complaint of swelling and the onset of left upper extremity resolved after cellulitis infection, which has since subsided with antibiotic treatment. She has no history of formal PT treatment. Okay, so this case was a patient who had actually, had a battle with cancer a couple years prior. All right, and she was managing things pretty well, but hadn't been sent for education on the lymphedema risks and what to be managing or watching out for. She also came with some limitations in shoulder range of motion, where she would have benefited maybe from like the Strength ABCs program to enhance her shoulder motion. So we had a number of things to address there with her, but she ended up developing an infection after working in her yard. She got a bug bite, it turned into a cellulitis infection, and then bam, her arm swelled up, and it was lymphedema, okay? And now chronically, we're managing that. So to treat that, we're doing full sequence manual lymph drainage, including abdominal sequencing and axial inguinal anastomoses. Compression bandaging of the full arm, including finger bandaging, skin care, patient education, managing infection risks, exercise routine, including muscle pump, elevation, left upper extremity range of motion, pectoral stretching, and postural strengthening. And then once optimal reduction is achieved with this patient, we are fitting her for a daytime and a nighttime garment because of the severity of the edema in her arm, including compression sleeves and a gauntlet or glove. And then this patient is also going to be set up with a home compression pump for long-term management. That kind of wraps it up and kind of summarizes just the top, skimming on lymphatics, understanding the lymphatic system. I hope you guys benefit from this. And if you have any questions, please feel free to reach out to me or even Steve, but probably preferably me because Steve's a very busy guy directly. And here's my contact information. I'm at the McCungie office, and there's my email. Thank you guys again, and have a great day.
If anybody has any questions, please feel free to turn your mic on and speak, or you can type into the chat. All right. Well, thank you very much for your presentation. I do have one question. If a lot of people are concerned about delays in getting care, is lymphedema something you need to get addressed as soon as possible, or is it something that can be delayed, or what's ideal?
I don't like the term delay,
Okay.
by any stretch of the imagination, because we're all about early intervention, early education. The faster we get to it, the better. However, I will say that it is generally not a pressing matter in a sense of if you have a patient that calls and said, I had a sudden onset of swelling, it came on overnight, or it just came on this week, odds are that's not lymphedema. That's something that needs to be handled by their family doctor or urgent care or the ER, because we want to rule out the red flag items like a blood clot or infection or something like that. Typically, I'd say from recognition of the problem, if it is more lymphatic in nature, you want to see that patient at least within a month's time. I wouldn't want to delay it any longer than that.
Thank you. Any other questions?